Okay, so let's move to the next topic, which is the Holy Grail in SEL. No, I'm joking, of course. It's a new topic. Now, oh, well, it's a little style difference. However, the good news is that we came to the very same conclusion via two different studies. So I will skip these useless slides. So the common points are that the OCOS formula is the least performing one, while if you use some machine learning, you can achieve way better results. Doesn't really matter if you stick to Eric formula, our formula. So the idea is what he said. So the greater the number of parameters we take simultaneously into consideration, the higher the accuracy. That's the point. So for instance, we found that if we take into consideration 16 different parameters, the accuracy is way higher. Why? Because in ICL surgery, there is some noise. So the noise is also related to the position of the ICL. As you can see from here, we have different positioning of ICLs. So here, the ICL in the first case is positioned in the sulcus, while here in the second and in the third picture is positioned half in the sulcus and half is resting on the ciliary body. And here in the last picture, you can see that the ICL is not in the sulcus, which is clear, while is resting on the ciliary body. And this is the vast majority of cases. So we have some noise. And if we take into consideration many parameters, we come to the very same conclusion that machine learning is helpful, and we got the very same results. So the most important parameter is, of course, the ICL size, which is quite obvious. And also the second most important parameter is what Eric said, lens rise, which is missing in the OCOS formula. And then all the rest. We have the distance between the scalar spur, the white-white, the decay, the age, and all the rest. So pay attention to the details, and newer formula take into consideration many more parameters. And I believe this will be the best solution. So of course, probably the best solution out there is the UVM, while if we stick to the OCT, the MS-39 is by far the most convenient one. But I wanted to share with you a few nice cases of ICL seen with the MS-39. So this is the Holy Grail. So this is the best sizing after the surgery, which is 500 micron. But sometimes we get results like this, which is, of course, as you can see, a very high vaulting after surgery. In this case, we waited 1 week more, and the result was this. So, of course, we decided to remove the ACL. So, I would like to clarify that the most important aspect, I believe, Eric, you can agree with me, is not the vaulting itself, but is the angle. So if the angle is smaller than, let's say, 20 degrees, 15 degrees, so you want to replace the ICL. Otherwise, you can leave it. But in a case like this, of course, the angle is very narrow. There is some edema here, so we decided to remove the lens and to place a smaller one, which is this one, as you can see. Here on the opposite is an ICL with zero vaulting, so there is no clearance between the crystalline lens and the ICL. But this was done on purpose because I needed to perform some iris suturing, so that was a shield to protect me, but you can visualize very well with the MS-39. This is a case of extreme vaulting. Of course, this was not me. This is Francesco Carones. This is his image. Of course, in a case like this, you want to remove the ICL immediately. And the reason of that was the presence of cysts behind the iris that pushed ahead the ICL. And this is the eye after the removal. On the opposite, this is another case from Francesco Carones of zero vaulting before and after removal of the ACL. Well, now let's move to some keratoconic eyes. So, when we deal with keratoconic eyes, they behave differently because they are outliers, and so they don't follow any rules, so they are outliers for any formula. And in general, you need a larger size for keratoconic eyes. And you can tell from these cases, so this is keratoconic eyes, both eyes. And of course, the vaulting was zero, as you can see here, because this is a huge anterior chamber, as you can see. So we decided to get a new ACL 2 steps bigger, and this is the result after the surgery. So once again, what is important is not the number that you read here, which is 850, but the angle, which is now a very nice angle. Another case of keratoconus. So this is a case of extreme keratoconus in the right eye and mild form fruit keratoconus left eye. And also in this case, so this is the right eye. Of course, we didn't implant any ACL here. Here we implanted the ACL following the formulas, but we got a very low vaulting, nothing vaulting. So of course we explanted the ACL and put another one bigger. So the message is that when you deal with keratoconic eyes, try to choose a larger size of ICL. This is another nice case of extreme high vaulting, and as you can see, this was a hyperopic ACL because you can see the shape, which is positive, and you are missing the central hole. This case, of course, the vaulting was too high, was 1.5 millimeters, and of course, we decided to explant this ICL. As you can see from here, it was extreme, so we removed and went ahead with the refractive lens exchange. So I wanted to share with you this interesting case, which is quite rare in ICL surgery. And once again, the anterior sigmoidosity is very useful in your decision-making process. So she is a 51 years old woman. The ocular history was perfect, unremarkable the anterior segment, and she was very high myopic, minus 13 diopters of myopia with some astigmatism. These were the corneal maps, right? So the anterior chamber was 3 millimeters, and this is the left eye, and also here the anterior chamber depth was 3 millimeters. Everything was unremarkable, as you can see. We implanted the ACL, and the day after, everything was perfect. So the visual acuity was 20/20 left eye, 20/20 right eye with a small negative target as we wanted to have. So just perfect surgery the day after. But the patient came back after 3 months for the follow-up visit, and yeah, came back after a few months. So the vaulting was a little bit shallow, but still present. So no special issues here. Well, this was probably due to what we found, high pressure. High pressure in this eye, yes. So the pressure was 36. Still, the vision was good. High pressure. So not for very long. So what to do now in this case? We decided to put the patient under betamethasone and fixed combination bimatoprost and timolol and wait 1 more week. She came back and the situation was even worse. So the vision was severely blurred and the pressure was 50. What to do now? So also thanks to the OCT, we could see some fibrin here clogging the central aquaport. What to do now? Oh, quite dangerous. Now, we just removed the ACL, not before, yeah, but look at the incision. Not exactly because of the pressure. Yes, but before doing anything, we decided to go ahead with a gonioscopy. And guess what? There was a lot of pigment inferiorly, right here. It was a pigment dispersion because of iris chafing against the ACL, which is quite rare, but it still is present. So we removed the ACL. This is after the removal, of course. The day after, everything was perfect, of course. The myopia was back, even stronger than before because of the edema of the tissues. And the pressure now was 8. 1 week later, the pressure was 45. So she was a cortical responder. We discontinued the betamethasone. We went ahead with phaco, and now she's a very happy patient. So this is another nice case I wanted to share with you, and this is very fresh. This is a patient that I saw last week. So this patient is keratoconic, as you can see, with a small keratoconic, and this is a hyperopic lens. This is on the horizontal meridian, and this is on the vertical meridian. So there is something wrong here. What to do? This was the day after, probably. So we waited 1 week, same. We waited another week, the same. So we decided to rotate 90 degrees apart the ACL, and the day after it was just perfect. So once again, it's really helpful in understanding the position of the haptics of the ICL. And we also did the UBM, and we found some cysts in that position. That's why we decided to rotate the ICL. Another nice case, another keratoconus, as you can see. This patient had a keratoconus both eyes, and this was the severe one. This is after the surgery. Everything was perfect, apparently, but the patient was complaining of ghost images, double images, even if we were on spot with the refraction. So we ran the Reinstein software to get the best positioning of the ACL according to the postoperative objective refraction. So we rotate the lens 20 degrees counterclockwise, and now this is a very happy patient. And just a few slides I wanted to share with you. If they are not involved with the ICL, but I believe they are meaningful in refractive surgery. This patient underwent hyperopic refractive surgery, as you can see here from the slides. And the optical zone now is a little bit small with some irregular astigmatism. Okay, yes. So this is the map before the surgery. This is the situation now. And the patient is complaining of ghost images, bad vision quality, which is, of course, coming from the small optical zone and the irregular astigmatism. So what to do? We wanted to do an enhancement, but once again, let me show you how useful is the MS-39 in these cases, because we knew the depth of the flap that we did years before, but now we need to take into consideration the regression, the refilling of the epithelium in the periphery, because you know that with the hyperopic treatments, we remove the stroma from the periphery, and there is now epithelium. So we measured everything, but you can see even better here with the anamorphic display. And in a case like this, you can see how thick is the thinning of the epithelium in the periphery. So a new flap would be maybe a flap of 250 microns. So we decided to go ahead with a PRK in a case like this, because there was some melting of the original flap in the periphery, and relifting the flap was too dangerous. So PRK was the solution. But let me show you another nice case of intraoperative use of OCT. So this patient got an accident during the first LASIK. There was a flap tear at the end of the surgery. We can skip the movie because we are running late. But I wanted to show you that in this case, we decided to go ahead with a second LASIK with a new flap underneath the previous one. But let me show you once again this anamorphic display, how useful is. So before lifting the second flap, we wanted to be double sure that it was not intersecting the first one. And as you can see here, it was larger and deeper, not intersecting the first one. So this is the way to go ahead in these cases. So thank you, Francesco, for developing this tool. Thank you.